it's a good afternoon from and on behalf of the three co-sponsors of this platform that we all, the University of Washington, Sambodhi Research and Communication Organization, as well as ISRN India, are planning to launch with the aim that will be actually discussed with the two organizational representatives who will follow soon after I finish introducing the topic. But basically, COVID-19 is what we all been spending almost most of our time gated out of the communities back into our homes, and the organizationally this epidemic or this pandemic has challenged across not only the lives but also the livelihoods. So we will possibly see what has happened in the past 4 months, and soon the speakers will take on, but I will just introduce the topic. So essentially, I'm going to show only 3 slides with the COVID-19. The major characteristic of this pandemic, as we see it, is between the people who come with disease and symptoms versus people who are asymptomatic. I mean, this is not unusual for an infectious disease epidemic, and especially the respiratory epidemic. But what it shows actually is that out of the 10 people who are actually infected, 2 of them have some form of disease. A quarter of the 2 would have very critical severe illnesses requiring an ICU, while the 75% of these 2 with disease are mild and moderate and do not necessarily need any ICU interventions, but may require hospitalization. So that gives us an impression of what kind of health services we are looking for. The major concern really goes around here, the 8 of the people in the iceberg. So this is what I'm depicting as an iceberg. 8 who are asymptomatic, and most of the time they are left out of the testing system in most countries because they can't cope with it. And they are the ones who indefinitely, but for certain period of time that we are hearing now scientifically, are able to transmit infection and are very, very important from the epidemic point of view. The next, please. There are essentially 4 stages of COVID-19 that I think we all want to catch on with. The stage 1 and stage 2, where most African countries and the participants who are connected with this platform, they are actually in stage 1 and in moving gradually to stage 2. So the stage 1 is where the infection is introduced for the first time, while the stage 2 is the local transmission to close contacts and their groups and their own families and communities. The third one is, which is a massive exponential transmission that occurs in terms of communities where people are not able to trace the source of infection. And stage 4 is the widespread outbreak of the epidemic, which is presently, of course, has no end in sight, and most of the countries like US, Italy, and Spain are going through those phases and maybe gradually settle down.
And a very warm welcome to all our speakers and participants. As Dr. Hira mentioned, I represent Sambodhi Research, one of the co-founders and co-sponsors of the Global COVID Network Initiative that were held between various actors across the public health landscape, including policymakers, including academics, implementers, public health professionals, as well as medical practitioners. And it was an outcome of a felt need for a platform which could capture and disseminate knowledge, insights, learnings, and practices in responding to pandemics such as the COVID-19 pandemic across various regions. The network has a strong focus on South to South inter-regional knowledge sharing and learning. But having said that, we welcome participation from all corners of the globe. We feel that would just add to the network. Over a long term, we hope to make the network a self-sustaining resource for sharing, for learning, for collaboration on responses on outbreaks. And to start with, we've started with the schedule of 6 webinar sessions. Dr. Hira talked about those sessions. And they essentially plan to address the impact of policy action on COVID-19 on the ground. Now, before I hand over back to Dr. Hira, I just wanted to highlight one of the primary reasons why we thought this network would be important and critical. And that's because the varied response that we're seeing across regions. This is an unprecedented pandemic. We haven't seen the likes of it in most of our lifetimes. Um, Different countries are at different points in the pandemic cycle, and hence their responses are being shaped by where they are, by the challenges they face on the ground, the resources that are available to them, the populations that they're dealing with, and the intensity of the outbreak, and so on and so forth. And hence also their strategy in dealing with the pandemic differs quite a bit. From a country-to-country perspective, from a local government to a local government perspective as well, we are seeing government response differing in terms of the lockdown. So some of them are buckling up and strengthening their lockdown and containment strategies, while others are talking about opening up of services and economies. Um, a strong case in point can be made about testing strategy as well. If you look at the graph on the right, you'll see that different countries are testing differently. And this is for a variety of reasons, which are very country specific as well. But all of this kind of leads to the point that we need a platform which can capture and document insights from the different responses as well as the outcomes of these different responses to ensure that there is a global discourse, especially focusing on the global south, uh, on potential kind of responses to challenges with respect to pandemics and their outbreaks.
I'll just introduce the organization like ISRN Indian Social Responsibility Network. Basically, is the network is a very young network, just 2014 is establishing, and we are working with the voluntary organization, corporate experts, social workers, and the government with the motto of like relationship building beyond funding. That is our slogan, like as we are working. And with over 600 associated voluntary organizations across the country, the organization is trying to make a difference at grassroots level. So ISRN, through its multifaceted approach, is working innovatively in the sector pertaining to health, education, research, and capacity building. And also, it has been able to deliver on the line of sustainable development goal like, related to good health and well-being, quality education, affordable clean energy, and water and sanitation. So, and nowadays we are working in COVID-19 for so many things like with the objective to support the frontline functionaries and other who are working round the clock to control the pandemic. We have created volunteer reserve force platform where almost 5,000 volunteers from almost 27 states and the union territory have already registered. So ISRN and its member organization have basically been working in a three major area. Like one is mass awareness generation through social media and different platform, and second one is distribution of cook food and grocery items to the needy person, and the third one is the sanitation kit to the needies, and also we are working with the government for the surveillance to support for tracking system, tracking patients and infected populations. So it's a few things we are doing, and we are also did some dialogues with our member organization with our vice chairperson, Dr. Vinay Sahasbudhe, He's a member of parliament in Rajya Sabha. He is also a president of Indian Council for Cultural Relations. And we conducted 3 states workshop, one for Bihar, Uttar Pradesh, and Uttarakhand in different days. So these initiatives carried out on ground by voluntary organization and are then being compiled and documented in a Corona Relief Bulletin. That's relief bulletin. Those are the Corona relief warriors. We are compiling these stories in our through our bulletin. So where in it will provide a holistic picture of the activities carried out to the support people and the government during the lockdown period. The pandemic has hit all countries across the world, but however, India is doing better. It is my personal feel and can be modeled with a relatively low number of cases compared with the rest of the world.
Hello to everybody who's on the webinar. I'm very pleased to be able to contribute. And Camille is just bringing up the first slide to introduce myself. And to complement what Subhash was saying, the special program on research and training in tropical diseases, most of the time when we're not in a COVID situation, we're dealing with diseases that are largely endemic, in fact, a lot of the tropical diseases. And then, of course, in WHO, there's a large program, the emergency program. Now, what we've just found by asking some of the people who we've trained in the past is probably not surprisingly, a lot of the people who've been trained through TDR, even though their training has been largely on the endemic diseases, they have acquired skills and expertise that they're now using as part of the COVID response. So just to explain that the main activities of TDR normally, do we remember what normal is like? I don't know. The main activities of TDR normally are on research and capacity development regarding endemic diseases. But these skills are often transferable, they're often generic, and they are being transferred, we know that, as people who we've trained in COVID response. So WHO, if you don't know the WHO COVID website, it is very good. That's a small infomercial from me as a WHO employee. Of course, there are a number of websites that are providing very good information. The Johns Hopkins website is very good, but of course also the WHO website is very good. And this contains the information that is transmitted to WHO from all of the 200 member states of the UN. So the numbers of people as of yesterday, the 27th of people, were coming up globally to 3 million confirmed cases and nearly 200,000 deaths. So this is, as everyone knows, it's a big deal. This is probably the biggest pandemic since the influenza pandemic that occurred just after the end of the First World War. And estimates vary very much, but perhaps about 20 and 30 million people died of the influenza epidemic in 1918, 1919. Commonly said, more people died of the influenza epidemic after the First World War than died of fighting and consequent causes actually during the war. And currently there are 4 countries that account for more than half of all the newly confirmed cases. These are the United States, the Russian Federation, Turkey, and the United Kingdom. Having looked at the situation today, I want to take several steps back in time. From the WHO website, I've made copies of some graphs to illustrate the evolution of the pandemic. And it's incredible looking back. It's only the 31st of December when China first alerted the WHO as to the grouping of cases of what looked like a new pneumonia in Wuhan. And this was the very start, the first alert that this was what has subsequently grown into be the COVID pandemic. So going back to the end of January, this is a graph. In those days, at the end of January, there were a total of 82 cases reported outside of China. And at that point, there were nearly 8,000 confirmed cases in China. And the bar chart shows these 82 cases. Now, by the end of February, we'd moved to this situation for the cases reported outside of China. These, the numbers on the vertical axis have now changed so that we're going up 300, 600, 900 cases, but still a very modest number of cases compared to today. So the color code is for the different WHO regions. And at this point, at the end of February, the sort of orangey color is the Western Pacific region, and that is largely representing the large number of cases, the relatively large number of cases in China and also in Korea at that point. And then the sort of pinkish, mauvish color is the European region, looking at the right-hand side of the bar chart, where we're seeing the beginnings of the epidemic in Europe. And then the other main element here is the purple color, which is Eastern Mediterranean, that is mostly the epidemic that they had in Iran. So at this point, at the end of February, this is only 2 months ago, incredible.
You can see all the epidemic for COVID is found in Kinshasa. So why Kinshasa? Because that's the capital area where all the tourists, the business people who are coming from Europe, the big airport is in Kinshasa. So that's why the COVID is found more. And then we find five cases in North Kivu, near Rwanda. All these five cases are healed. And then in the South Kivu, we have 4 cases. These 4 cases, it was a 10-case people in quarantine. Only 4 was confirmed. And all the 4 are healed. So the Ituri, we have 1 case is healed. And the Kwilu, 1 cases. And the Katanga recently, so 1 cases. So we have more the cases in Kinshasa. All the province cases except for Katanga, not yet, and under monitoring. So what we are trying to do in Congo as a measure in our fighting for the COVID, we're just trying to reduce the reproductivity rates. So as you know, the reproductivity rates equal to transmission efficiency, beta, multiplied by C, the contact, the exposure rate, and by duration of infection. So what do we do? We're trying to reduce the reproductive rate at 1. So if we manage to reduce the contact exposure less than 1 over beta to T, so that's what we are managing. Since we don't have a B, we don't have to work on B, on beta and D. We need to have a treatment. We need to have a vaccine. We don't have. So what we are trying to do is to work on a contact by social distancing, quarantine, washing hands, and mask. So this, I think people are changing their behavior. It's almost the way we fight Ebola. So that's the formula for reproductive rate. That's why we are working on that. How do we end it? So we need to do a testing like a WHO say. But you can see in Congo now, the testing is only in Kinshasa. So the lab for testing to all the provinces, you know, Congo is like a continent. Now they stop all the plane moving. So we are using like the UN plane to send the blood, if there's a plane or not. So all this is to delay. So we have only viral testing lab is in Kinshasa, problem. But contact tracing, so we are trying. There are so many innovations. Like here in Bukavu, they are making some program for and phone contact tracing using the phone, the smartphone. Like CamCare also proposed us to do the same thing. So then for the treatment, like you know, we are just using the protocol using in France with chloroquine. So we are trying to borrow also the Indian and prophylaxis. So people were contact positive before they develop the disease. We give them the program they're using for Indian, but we adapt it. So we did 400 milligram twice for 3 days, and then 1 tablet for 11 days. So we do like trying like to do some study on that to get the evidence-based practice. Okay, we don't have a vaccine, so but the monitoring, we have a monitoring system in place, and preparedness. we have at least so many hospitals in the country. Only 3 hospitals are ready to receive the cases for coronavirus. So we don't have those equipment, respiratory. We have only 50 representatives of the whole country. It will be very difficult for us, but still we're trying to use our experience for the past experience for Ebola.
The concept that we need to implement policies and non-pharmaceutical interventions to buy time so that we don't overwhelm the healthcare system capacity and therefore are able to save lives by continuing to deliver high quality care. The other thing that we're trying to buy time for actually is to give researchers a chance to the kinds of, to develop and test actually, the kinds of tools that we need to deal with this pandemic: diagnostics, drugs, and vaccines. Another way to think about flattening the curve is that we actually want to increase the doubling time of national and localized epidemics. And hopefully this will work here. Good. This is encouraging. Yes. Let's see if we can do this. I think this is a beautiful depiction. The end point of that video would have shown you this, this figure. And you can see, for example, for the United States, how the doubling rate declined from roughly a doubling rate of every 2 to 3 days to now about every 9 or 10 days for the United States. And here you see the same or an analogous set of estimates for major metro areas, with Seattle having now moved from decline to about a double time of every 2 weeks, which really gets us to the point where we start to be beginning to be able to control this epidemic right here. Again, I want to emphasize, however, that there is probably substantial underdetection of cases. So people have raised questions about the reliability of some of these estimates. But overall, I think the message is that we are beginning to see traction with some of the policy interventions in some cities and some parts of the world. So the real question, of course, is what do we do to flatten the curve and ultimately control this pandemic? One thing that I learned as an infectious disease physician and epidemiologist is that if you want to beat a virus, you actually have to think like a virus. So if I were a virus, I would most of all want to do 2 things. I'd want to survive as long as possible, and I'd want to reproduce as much as possible. One of the best ways to spread and both survive and reproduce is to link my spread to essential human functions. And 2 of the best ones are breathing and sex. This virus, of course, is a respiratory virus, and the primary transmission mode is large droplets as a result of coughing or sneezing. Second thing is to travel undercover. We do know that this virus is transmitted even in the setting of asymptomatic, minimally symptomatic, or pre-symptomatic cases. Although I have to say we don't fully understand how efficient those different types of transmission are. The third thing is if we want to, as a virus, I would want to stay as infectious as long as possible. We're still learning exactly what the infectious period is, but it's pretty clearly longer than the symptomatic period. The fourth thing is that I want to be slow to kill or severely debilitate my host, so that I could have a way to be carried to the next, to infect the next person. And with more than 80% of cases being minimally or moderately affected, I think I'm in good shape here. Finally, I want to be able to change my appearance, change my coat. And here we're still learning exactly what kind of mutation or evolution rate SARS-CoV-2 has. Which brings us to the concept of the reproductive rate, or R sub 0, of infection, the average number of new infections resulting from each index infection. The reproductive rate is the product of three factors: beta, the transmission efficiency; C, the contact or exposure rate; and D, the duration of infectiousness. So to control and ultimately end a pandemic, we need to drive R sub 0, or the reproductive rate, down to less than 1. So one way to do that is to decrease C, the contact or exposure rate. And that's what we do with social distancing, things like hand washing, masks. But if we want to be able to drop back and de-escalate from social distancing, let our contacts with other people start to increase, the other way to do that is through vaccines or treatment, which decrease beta, the transmission efficiency, or the duration of infectiousness.